Today we have with us Dr. P.N. Agarwal to discuss this topic with us. Welcome, sir.
Good evening.
Okay, sir. Shall I go ahead with the history?
Yes, please.
We have a 31-year-old gentleman who's a resident of New Delhi and an electrician by occupation. He presented to us with the chief complaint for swelling along the scar of previous surgery for the last 6 months. He was apparently well when he first noticed the swelling in the upper abdomen along the scar of the previous surgery for a duration of the last 6 months. The swelling was insidious in onset. It has progressively increased in size. Initially, it was approximately 3 cross 3 centimeters and has progressed to 10 cross 10 centimeter size over the last 6 months. It reduces spontaneously on lying down and aggravates on standing, cupping, and straining. Patient underwent a surgery for bowel perforation 1 year ago. There is a history of pus discharge from the wound in the immediate postoperative period. His skin sutures were removed and resuturing was done on the 15th postoperative day. However, no documents are available with the patient regarding the nature of the surgery. There's no history of irreducibility of the swelling or pain over the swelling. There's no history of skin changes over the swelling, constipation, non-passage of feces flatus, abdominal distension, nausea or vomiting. There is no history of chronic cough, constipation, or urinary complaints. He has undergone a laparotomy for bowel perforation 1 year ago. He does not have any diabetes, hypertension, asthma, any comorbidity. He's not taking any drugs at present. There's no history of hospitalization or any other surgery. He is a non-smoker. There's no history of tobacco or alcohol consumption. He has a normal bowel and bladder habit. He's a non-vegetarian by diet. And his family history was non-contributory. To summarize, sir, we have a 31-year-old gentleman who has complaints of swelling along the scar of previous surgery for the last 6 months. He has undergone a laparotomy for bowel perforation 1 year ago, following which he had developed a superficial skin infection, for which skin sutures were removed and resuturing was done 15 days later. He has no significant past personal or family history.
So anything till now, I think this is the very common scenario. All postgraduate must have seen this kind of problem. When any incision in the abdomen develop liable for development of incisional hernia, and it is roughly incidence is around 15 to 20%, depending on the various series reported. And this scenario, this particular patient, I think he's operated for perforation peritonitis. So this is the highest incidence for development of incisional hernia. As far as history is concerned, which we have already mentioned, there are 3-4 things. One is smoking, which is very important, because if he's a smoker, then it should be at least stopped 4 to 6 weeks prior to when you want to repair any kind of repair that will come later on. Another thing is diabetes. Third thing is BMI. So we'll come to physical examination for obesity. And last but not the least is, of course, nutritional status. Patient is malnourished, particularly. We'll come to that when we'll talk about investigation. So these are the things which in general history should be taken into account. And of course, any drug like corticosteroid, chronic taking because of some or other problem, maybe COPD or some other thing. And of course, urinary obstruction or LUTS and constipation, all of you know, for any hernia, and particularly for incisional hernia. So that is in the history important point. Another thing is it recurrent incisional hernia, means already been operated for incisional hernia and it has been developed, or just after first surgery. And in this patient, I think cause, all we know that infection, hematoma, chronic cough post-operatively. But in this patient, perforation peritonitis, all of us see in our hospital daily. All postgraduate or resident operates on still perforation peritonitis is very common emergency situation, either enteric or tubercular or appendicular perforation. And last but not the least is traumatic. So this is a typical history. I think as far as diagnosis is concerned, on the basis of history, it's not a rocket science. We are dealing with incisional hernia. If anybody asks anything, particularly in the history so far, any participant can ask anything. If I'm able to answer, I will definitely. Okay, Adiba, if there is nothing, we can move.
On the general physical examination, the patient was
Yes.
conscious. The patient was conscious, oriented, and alert. His weight was 65 kilograms with a BMI of 22.9 kilogram per meter square. His blood pressure was 110 over 70, a pulse rate of 90 beats per minute. He was maintaining saturation on room air. There was no pallor, cyanosis, clubbing icterus, lymphadenopathy, or edema. On the per abdomen examination, on inspection, the umbilicus is central and inverted. There's a midline scar which is present from the epigastrium to the hypogastrium. Swelling is present on cuffing, raising head, which is approximately 10 cross 10 centimeter in right size and reduces completely on lying down. There's no visible peristalsis, dilated veins, or any skin changes over the swelling. The swelling, sir, is not apparent when the patient is lying down, and it becomes apparent only when he's cuffing or he's asked to lift his head or do a Valsalva maneuver. And there's a scar that is present, which is extending from the epigastrium to the hypogastrium, a midline scar. And the swelling is apparent only in the upper half of the, along the upper half of the scar. On palpation, the findings of inspection were confirmed. There's a 10 cross 10 centimeter swelling, which is apparent on cupping. It is soft in consistency, has a smooth surface, rounded margin. It is non-tender and it reduces spontaneously on its own. There's a defect that is palpable, which is approximately 6 cross 6 centimeters. There's no hepatosplenomegaly or any other palpable lump in the abdomen. The swelling is dull on percussion. There's no free fluid in the abdomen. The liver span is 12 centimeters and normal bowel sounds are heard, which are 1 to 3 per minute. The systemic examination was also normal.
I think we have already mentioned everything about the examination. Diagnosis, I have already said, not a problem. It is incisional hernia, obviously. And the purpose of examination here is to feel the defect size, transversely particularly, longitudinally it may run along all of the scar line, and look for any other defect which may be there on cuffing. Sometimes that may be there from drain side. Sometimes there may be another defect which patient may not notice, but you can see on examination. That is one thing which should be always mentioned. And of course, you have already said about the free fluid. Ascites, we have already said. So these are the part of, particularly the size of the defect should be measured exactly because it has a bearing on the type of the treatment which you are going to decide about that. So that is what should be done. I mean, that is what is the examination size of the defect horizontally as well as vertically, and look for any other defects. And of course, general examination as you do for abdomen for any other lump or any other pathology, that is what is to be done. That's all.
So Alpana has asked a question that in the history, exact location of the swelling has to be mentioned, or is it okay to say that the swelling is present over the previous scar?
Previous scar, maybe in the epigastric region or in the umbilical region around whatever anatomical side, what we say, you can say that because that will come in the classification also. All of you know the midline or lateral. So I think exact means you say it is in the supraumbilical region or in the hypogastric region or in the epigastric region. You can mention that. There is no problem. I mean, the patient is standing coughing, he is mentioning it is there. So I think it need to be mentioned. There is no problem in that. Nothing wrong in that. Why not? Because if it in the flank or subcostal region, it comes under category of like you already midline or lateral. So I think it should be mentioned. There is no problem in that. Just what? Why not?
So the last slide is about the intraoperative pictures for this very patient. So we have a
No, when
defect
this
which we
patient, the
have.
question comes, what is next? What is next? Operative is all right, but the question is how will you evaluate the patient and what needs to be done? This patient has required surgery. All right.